طيب, in order to read the ECG, first the label, then the heart rate. How you are calculating the heart rate?
بطريقتين يا إما نشيل ال
300
R wave
divided by the number of
عشان
our big
أو
square
نقسم
number.
عدد المربعات.
There is many ways.
300 rule.
Yes, there is many ways you can do that. The easiest way is the 300 divided by the number of the cubics between RR. If it is irregular, you can divide, for example, 3 area between RR. So 3 RR, you will divide 900 divided by the cubic between the 3 RR, or 300 between 2 RR, 600 between 3 RR, 900 divided by between the cubics of the 4 RR. So it is a 300 divided by the cubics between 2 RR. How much is the normal heart rate? 60 to 100. Means if it is above it, we will say this is tachycardia. And below 60 by definition is bradycardia. Whether it is significantly clinically or not, it is the name. Yani every patient who have persistent rate above 100, we can say tachycardia. Maybe sinus, maybe normal, maybe he is running. We are not talking about anybody now. It is just a term. All right. So we calculate the rate. Then the rhythm. The rhythm, that means there is B wave before every QRS. And if there is B wave between every before every QRS, that means the electricity is coming from the SA node to atrium. Okay, and to AV node to bundle of his Purkinje fibers. B depolarization here, QRS depolarization here. So BQRS, that's a normal electricity. That is a sinus rhythm. Sinus means come from the sinoatrial node. Rhythm means there is a harmony. There's a normal journey by the normal pathway. That is when to say sinus rhythm means electricity from the sinoatrial node going in a rhythm way. And there is P wave before every QRS. Type. BR interval, it should be not it should be not more than 5. If the BR interval is more than 5, what we will call that?
First
Prolonged
degree heart block.
prolonged BR
Prolonged
interval, and this is
Prolonged
mostly
BR.
a
Heart
first degree heart block. طيب, if it is shorter, less than 3 cubic, what we will call that?
Sinus tachycardia.
No. It is like a short PR interval, right? طيب. If a delay, if a prolonged PR interval is a first degree heart block. طيب, a short PR interval, what are the differential diagnosis or causes of short PR interval?
WBW.
Tachycardia, junctional.
Yes.
Re-entry
Wolf.
tachycardia.
Wolf.
WBW syndrome?
Yes.
WBW syndrome. Sometimes if it will be very subtle. You cannot see that there is there will not be the delta wave. You cannot see the delta wave. Sometimes ECG,
Yeah, AGL.
some delta wave. But the PR interval is very important. If it is short and you have a doubt whether there is delta wave or not, but you come back, calculate the PR interval. It is short. This will support you. So you can say this is a high suspicious of WBW syndrome because there is. I am doubt about this wave, maybe delta. But the short PR interval. Why short PR interval? نرجع للإلكتريسيتي بتاعتنا. Why in WBW syndrome there is short P wave interval? What is the problem? What is the science of the electricity that generate short?
Accessory pathway.
Because there is
Accessory
accessory pathway, so there is more electrical activity
So
of the
this
heart.
is the SA node. This is the AV node. This is here the polarization of the atrium, and the electricity came here to the AV node. Okay. This time, and from the AV node, there is bundle of what?
Bundle of
His.
Bundle.
Yes.
I just remember this name because I have another bundle for you. Bundle of his Purkinje fiber. This is normal PR interval. In WBW syndrome, there is accessory pathway. It is called bundle of Kint. There is bundle of Kint. Fast transmitting the electricity from the atrium to the ventricle faster than the time which is taken by bundle of His. The time is shorter than 120 milliseconds. Why? Because the bundle of kit are fast bundle. It is a muscular tissue actually. That is why they know from the electricity that this bundle of Kint is faster than the bundle of His. Bundle of Kint in the WBW syndrome is faster than. That is the significance of the short PR interval. One, in WBW syndrome, and we know why and how. What else?
normal
Junctional
interval.
rhythm, junctional AV nodal rhythm. In the AV nodal rhythm, because there is here the electricity from here come back again, re-entering. AV nodal rhythm, or the rhythm come from the AV node. The rhythm for the ventricle come from the AV node. So it doesn't take time. It will be very short PR interval. What else? The lone Ganong living syndrome. There is accessory pathway, same like the WBW syndrome. The share, the force, if the atria have a foci here generating the electricity. They are calling this low atrial rhythm. Okay, sometimes maybe a normal variant that there is faster transmission. So short BR interval could be normal, variant, could be low atrial rhythm, could be junctional rhythm, AV node, could be accessory pathway in long Ganong, or accessory pathway bundle of Kint in WBW syndrome. Any question until this point? All right. So that is a BR interval. The QRS, which is a depolarization of the ventricle. Come here. We have two ventricles. Why there is one wave normally? Why we have one wave for two ventricles? Why we have one wave for two?
Because it is a summation. Because it is summation of electrical activity.
The electrical activity, because the electrical activity for the two ventricle by same velocity of the two bundles, the right bundle and the left bundle, because they have bundle of His, right bundle, left bundle. You will know now there is bundle branch block, how it will appear in the ECG. There is right bundle, there is left bundle, and there is Purkinje fibers here. The normal bundle of His, the normal right bundle and left bundle, the same. So the electricity will go here and there at the same time, producing one spike. So there is two abnormalities here, minimum. If the electricity is not from the bundle, if this bundle have ischemia in the area of the bundle and damage of the bundle, so there will be generator here. In anywhere from the muscle become again. The muscles of the ventricle or the heart have the automaticity. Any muscle can change into a rhythm generator. Subhanallah. Any muscle, any part. If the electricity stop, anyone can take the roles. أي muscle ممكن تمسك الراية. الراية ما بتسقط بسهولة. So any cell, any muscles can become a generator. If there is damage to the bundle, any muscle can take the role. But at this time, the electricity will be what? The velocity will be what? Will be what, anyone? Will be broad, because it take long time. That is a ventricular rhythm. That is not only the synchronization, there will be broad complex. Type. This is if there is no bundle at type. If there is one bundle is affected, there is ischemia in the right heart and the right bundle is affected. So the electricity will go where? To the left fast. The left started to depolarize. the left will realize that the right is not depolarized yet. It will send electricity here to charge the right, because the left cannot work without the right. Then the electricity will reach the right. It will, catch. And this is why in the bundle branch block, whether it is a right or left, there will be two spikes. One is depolarized normally, the other is depolarized from the NEPR, from the normal. Of course, if the electrodes are here, it will be like this. If the electrodes is here and the going from this way, be like this. We will come to see it in the bundle branch block.
هي بص هنا بيحصل ديليت في الديبولاريزيشن لما يجي من
Of course, because it's coming from muscle to muscle, not distributed by nerve. It is from muscle to muscle, from cell wall to cell wall. So it will take a longer time.
اوكي
طيب. So the normal duration is 120. Three small. Why three small? Because it is fast fibers. The Purkinje, the bundle of his right and left and the Purkinje fibers are very fast. But despite the muscle of the ventricles are large, the nerve are very efficient. Okay. QT interval, it is measuring the repolarization because it is measuring the T wave. The T wave is a repolarization in which the heart muscle will regain the negative charge inside. So repolarization. And it is measured the ability of the heart for the repolarization. That is why it's measuring the electrolytes working in the repolarization, especially the calcium and potassium. All right. Hi. We said, forget about the axis. Don't waste your time in the axis. Why in leads for the wave? It is positive where? So if this is the chest, okay. And the heart is located here, like this one. And the electricity is going where? This direction. If we put electrodes here and here, it will be very positive because the electrode here measuring the electricity which is coming towards it, positive, will be positive deflection. So the B wave, which is measuring the atrial depolarization, the electrodes on these sides and in these arms and between the arm and the leg. So lead 1 and lead 2 and lead 3 all will be positive. Sorry, an AVF. Lead 1 and 2 and AVF. طيب, the V1 is here or here, for example. Here is the electricity is, half negative, half positive. So in V1, it will be, biphasic, starting negative, then positive. Right. ST segment should be isoelectric, which is another important one. T wave, again, the same. In lead 1 and 2 should be positive. Right. Now we finish the basic. So we can go to the checklist. And we will go to the arrhythmias and have examples. Any questions so far? Okay. Remember, if you didn't go systematically, even if your master missing, if you have no and the shape and the specificities of the leads, you can miss a lot of valuable information. Okay, so systematic. The rate. Sometimes it'll be only sinus tachycardia. And if I ask you, in a patient with a shortness of breath or chest pain, pleuritic type chest pain, or hypoxia, what is the significance of sinus tachycardia? 110, nothing else. Anyone? What you will put in your mind? Normal blood gas, maybe alkalotic even. But patient have shortness of breath. Everything is negative. Cardiac enzymes, normal.
Pulmonary embolism.
Yes, pulmonary embolism. See, the pulmonary embolism, it is very serious, and the only sinus tachycardia is abnormality. And we have patients who are our relative in another hospital. He passed, Allah bless him. They have only the abnormality. He's saying to them that I am having shortness of breath. And the only abnormality is the sinus tachycardia. And that sinus tachycardia actually, in the context of shortness of breath, were now the medical legal issue for the hospital. Patient have shortness of breath, everything is normal, X-ray is normal, blood gas normal, because in pulmonary embolism, the blood gas will not be abnormal unless it is a massive. Sometimes even you will have alkalosis in the arterial blood gas. The only abnormality may be the sinus tachycardia. Okay. After we count the heart rate, the heart rate, if the heart rate is 140 and everything is regular, still sinus tachycardia. But if it is 160, what is the significance of that? And the patient have only mild discomfort and palpitation.
SVT.
SVT. Just the cutoff point between the 150. So when you read the rate, you need to link the abnormality to the medical use of this abnormality, and what is the cutoff point for each. So above 100 in a patient with shortness of breath, you need to rule out pulmonary embolism. If it is above 150, you need to suspect some SVT, because very rare for a sinus rhythm to be above 150 at rest. And at that patient, you can try the adenosine, for example, if there is no contraindication. All right. Then we'll come to the rhythm. We say the rhythm, a harmony between the atrium and ventricle. If there is PE before every QRS, Alhamdulillah, this is sinus rhythm. Or regular pacing. That is a regular spacing. All right. Axis, I don't like it. Forget about it. Same like the question was, what do you do for living in the OSCE exam? I hate this question. And the axis have no that big significance. And in any lecture, we are talking about the axis. They will leave everything and concentrate on the axis. Forget about the axis. Don't read it in the ECE. The information in the axis, you will find it more clearly in other abnormalities. But if you want very easy way, the right axis and the left axis, and those who are the right the group of the right, they will be the head of the RR in the lead 1 and 2. In the lead 1
and 3.
should be in 1 and 2, both should be up. This is normal. If both are pointing towards each others, this is a right. If both are away from each other, this is a left. أصحاب اليمين مع أصحاب اليمين، أصحاب اليمين متقابلين على سرر متقابلين، وأصحاب الشمال مالهم متنافرين، كل واحد يلعب الثاني. Okay, in the right going towards each others, the left going away from each others, and the normal, both are going up. All right. Interval, we'll talk about that. Then we will come to the shape of the B wave after we finish the rate and the rhythm and the measurement of the internal PR, QRS, QT. This one should be 3 to 5 cubics. This one should be 3 cubics. This one, we will correct it and then read it. Right. Then we will come to the shape and whether up or down for the B wave, QRS, ZT, and ST segment. And especially the T wave, and more especially the ST segment. If the ST segment is up, that is ST segment elevation. If it is down, ST segment depression. I'm not saying MI. I'm not saying ST elevation MI. No, ST elevation. ST elevation could be MI, could be some many thing else, like what we are gonna see now. Not every ST elevation is MI, although we need to roll out the MI. But there is a lot of causes can cause ST segment elevation. So we can say just ST segment elevation, ST segment depression. In the context of a chest pain and troponin, that is MI. For example, if it's pericarditis, will be ST elevation in only it's pericarditis. Subarachnoid hemorrhage can cause ST elevation. Many things. Hi. We need to learn the checklist. All right? The rhythm, the internal, the interval, and the waves. And if there is any abnormality, which leads? And each leads will read a part of the heart. So after we know the abnormality, we can localize. And as I told you, the medicine, the art of the medicine is localization. After you localize, if you detect the abnormality, then link it to the site. Which heart? The right, the left, the atrium, the ventricle, the septum, the apex. Okay? Same like in neuro. If you have weakness, you need to know whether this is weakness is from a lower motor or upper motor neuron. And if it is upper motor neuron, in the spinal cord, in the brainstem, in the internal capsule, in the motor cortex, where? So we can localize and localize and localize until we reach the diagnosis from just a clinical, from just a reflex, or hammer tone. You can know from the full examination interpretation, you can localize. If a patient have a dense hemiplegia, where is the site? Dense hemiplegia, power 0. Where is the site? So examination, the right and left, both power 0. Sensation is affected. And there is facial nerve palsy, upper motor neuron type facial palsy. A lesion in the internal capsule, where all the nerves are coming to it in a condensed area. All the nerves come together. If it is damaged there. So this is a localization. Here is the same. If I have ST segment elevation in the V5 and 6, that means this is a lateral area, the lateral part of the heart, maybe the apex or the lateral wall. So this is a lateral. I will know this is from the circumflex artery. So we can easily concentrate when we take the patient to the BCI, easily concentrate on that area. Okay. So after we know the abnormality, we need to know which leads. And if we detect the leads, what about the other leads? Are they in the same area? Good support. Okay. Always in the clinical practice, check the previous ECG. What is the importance? Can someone tell me any example for the importance of the previous ECG if you have abnormality now? For example, if there is abnormality now in the ECG,
we always have to have a baseline in order for us to see what's going on.
yes. Like, examples. Example, if you find abnormality, first things, you will go to the records and open the old ECG. If it is there, alhamdulillah, no problem. You can just relax, or you can link it. You can depend on the clinical presentation right now, not in the ECG only. But if it is not there, you will raise the suspicious. For example, left bundle branch block. If the patient is having an old, there is a bundle branch block, same like the ECG, you have it right now. That means this is mostly an old bundle branch block. And the difference, because new bundle branch block is ST elevation MI equivalent. But if it is old one, if there is a previous ECGs with the same left bundle branch block, you will go back to the patient. You have chest pain and one does it started exactly, and then you will take the troponin and the other investigation. You will depend on the remaining of the investigation, not solely on the left bundle branch block. But if it is for the first time, left bundle branch block, you will not, in the patient with chest pain and it's new, you will not wait for the troponin. Patient should be taken to the PCI immediately before the troponin. For example, if a patient came to you with a chest pain, a severe central chest pain that is more with activities, ease with rest and morphine, and it is lasting more than 1 hour, crushing, sweaty, and he have hyperlipidemia and diabetes, hypertension, a family history of ischemic heart disease. Patient now have left bundle branch block. So you never wait for the especially if you are in the clinic, we'll send him by ambulance to the area where there is PCI. And in that area, you notify, they will be ready. They will take the patient without troponin to the PCI. They will do reperfusion. Okay, but if it is there before, then you will go to the patient and take a full history and do troponin. And of course, if in the hospital. If in the clinic, a current chest pain, you will refer immediately by ambulance to the hospital. They will do investigation there. You can go give only aspirin if it is in the clinic. Type. That is the significance of reading the previous ECG. Type. There is minor variation. For example, short BR, prolonged BR, there's some normal in there. There is physiological abnormalities. For example, if you have a patient, very athlete, body lifter, bodybuilder, and the heart rate is 40, blood pressure is normal, everything is normal. What do you think?
It's normal.
Normal variant.
Normal variant, unless there is something else. Okay. Right. So this is the ECG. How much is the rate in this ECG? This is like just to know the normality in each leads. For a rhythm, will depend on the lead 2. Why lead 2? Because it is matching the electricity journey. Okay, from right to left. It is iso to the electrical line in the heart. Measurement. B wave 12 millisecond. 3 small cubics. BR interval 3 small cubic to 5 small cubic. I mean 2 large 1 cubic. 1 large cubic. Okay. Axis, leave it. Yes. This is a lead. This is between the right arm and the left arm. And the heart is here. The heart is lying on its right side. القلب بينوم على جنبته اليمين. نايم على right heart. Right heart is facing the diaphragm. Okay. So this is why lead 2 going the same way the electricity going. And it should be strongly positive. And lead 1 كذلك. طيب both should be positive. If this one is negative, that means what?
Speedest.
That means the axis is deviated this way. It should not be negative. Lead 2. Okay? طيب. That is the meaning of the axis. If you are doing the leads, that is lead 1 is between the 2 arms, lead 2 between the right arm and the left leg, and lead 3 between the left arm and the... That is why we are not talking about lead 3. Why, Ejma? Why we are not concentrating in the axis for the lead 3? Because lead 3 usually is in between. In between, why? Because this is the electricity pathway here, and this is the lead 3 here. Yani it is not measuring. It's not good for measurement. No, it's not good for reading the waves. So lead 3, you cannot depend on in measurement of the wave, B wave, QRS, because it is not matching. It is going crossing the axis. So forget about the lead 3 in the wave reading. Clear يا شباب؟ طيب نجي ل very important lead AVR. AVR ده الأرضي وده الإلكترود، والكهرباء ماشية وين؟ The electricity is going where? This way. This is the base of the heart. This is the apex. والlead ماشي وين؟ The lead is going this way. So it's completely negative. Everything in AVR will be negative. طيب V1 here. Electrode will put it there, here in the right side, right to the sternum. And the ground here. So this is the V1 reading. And this is the electricity. So the V1 will be all negative. All will be negative. Why? Because it is going a measurement, the electrode measuring the electricity is going opposite direction of the current. So it will measure negative. Type AVL. The electricity is going this way, and this is going this way, it will read positive. Type V2 and V3 will be like biphasic. Because it is شوية من دول شوية من دول. Some from here and some negative and some positive. It is start negative and then end positive. So it will give us this reading. This is V2, 3. Right? V4, 5, 6. Will be completely and it should be positive, then positive, then strongly positive. What we are saying this, Ejma? Negative, biphasic, positive small, positive medium, positive large. What we are saying this? A very important finding. R wave progression. Progression of R wave. If there is a normal, if the electricity is normal, the R wave will be progressed from negative 2 biphasic, 2 small positive R wave progression. It's not progressing very well. That means it is negative, negative, biphasic, small, and keep small, not massive. What is the significance? What's your suspicious or differentials? شوف
معلش يا بص السؤال شنو؟
what is the significance of poor R wave progression?
Cardiac infarction.
That means there is no, the R wave is not increasing from V1 to V6.
Yeah,
It's
tachycardia.
normally what you said, no?
Cardiac tamponade.
If we have inverted P wave in lead 1 and poor progression.
Ventricular
will lead to-
contraction.
There is two abnormality in the R wave progression. There is failure of progression, and there is small amplitude. Small amplitude could be obesity or cardiac tamponade. Small, the ECG, the all ECG will be small, like the QRS complex will be very small like this. There is no the long one. There is progression, but the electricity is small. This is that means the transmission of the electricity to the electron outside the skin. There is some barrier in between, either fat or water or blood. Either cardiac tamponade or there is fatty tissue. Okay. I'm talking about poor R wave progression. Either a previous myocardial infarction, same like an old UF, poor R wave progression. You need to ask the patient when you have a previous MI or not. Mostly they have anterior because it is V is anterior. So poor R wave progression, there is in anterior old infarction, a previous anterior myocardial infarction. That is the most common one. Is the anterior MI. The left ventricular hypertrophy. Right ventricular hypertrophy. Left bundle branch block. There will be poor R wave progression. And the other causes of cardiomyopathy. All right. Any questions so far? Okay. B wave abnormalities. What are the abnormality? We know the normal. We have some hint about the abnormality. Now, we said the normal B wave should be 3 small square. All right. It should be 3 small squares. This is the length. The amplitude should be 2.5 mm in the limbs. The best one is lead 2. Best seen in lead 2, where the electricity is going the same way. عشان كده بيسميه rhythm lead. And in V1, it will be biphasic, or like this. That's normal. And it should be upright in V1 and 2 and AVS. And inverted in the AVR. لأنه AVR قلنا electricity is going opposite. So, in summary, B wave should be upright in lead 2 and negative in AVR, because lead 2 is going, the electricity is going this way. The lead is here. The ground is here. In AVR, the ground in the middle of the chest and the lead reading on the right side. So B wave in the AVR will be negative. In the lead 2 is be completely positive. And in V1 will be biphasic. Clear, يا جماعة?
Clear.
Okay. So we will enjoy reading the B wave now. Type, what is if abnormal? What if it is larger than 2.5 mm? That means the atrium is large. That means the right atrium is large, because it is more than, more than 2.5. That means too much electricity there. That means the atrium are large, especially the right atrium. And the right atrium will be large if there is, either block in the AV valve, or if there is stiffness in the right ventricle. And the stiffness of the right ventricle, if there is pulmonary artery high pressure, that will lead to and we are going from the lead now to the diagnosis. If we find a large B wave in lead 2, it will tell us, I am large right atrium. Come here. Why you are large? I am large because I am pumping the blood against a stiff ventricle. Why the ventricle, the right ventricle is stiff? Well, because the artery where I am draining the blood in, where I am pumping the blood in, is a high pressure. And why the pulmonary artery there is high pressure? There is high pressure because the lung is stiff. And why the lung is stiff? Because the lung is stiff because there is patient is COPD, or there is block in the artery, pulmonary embolism. See, localization. From a small graph, you reach a diagnosis of pulmonary hypertension, pulmonary embolism, COPD. This is if the B is peak, is large. Now, if the B wave is broad, the problem is not in the amplitude. The problem is in the time. So take time. Broad. Broad, that means the left atrium is enlarged. Come here. Why you are enlarged, sir, left atrium? Because I am pumping the blood against the stenotic valve. Why the valve is stenotic? Maybe a rheumatic fever, maybe. What else? Maybe the valve is normal, but the ventricle is hypertrophied. What else? Maybe the ventricle is hypertrophied because it's hook'em or because of there is hypertension. So from the Beeble Monell, we can diagnose that is a left ventricle hypertrophy or the left ventricle hypertrophy because of hypertension or because of mitral stenosis. That's why it's called bimitral. So Beeble Monell is a high amplitude. And we know the causes. Right side causes. Broad B wave, bimitral, because of left atrial enlargement. See? All right. Absent B wave, there is no depolarization of the ventricle, of the atrium. Sorry. No organized electricity. This is atrial fibrillation. Absent P wave. And sometimes, believe me, only the absent P wave can help you detect atrial fibrillation. Very important. Absent P wave telling you that there is electricity is going, but it is not organized. There is no depolarization. No organized electricity going to the muscle. Because the current will remove each other's. So, what is the definition of atrial fibrillation? Not irregularity. So, irregularity is a result. But the electrical, the definition is by the absence of P wave. Sometimes there is many irregular, abnormal rhythms, but it is not atrial fibrillation. Only the normal rhythm, abnormal R in the presence of absent, or sorry, in the absence of P wave. Here we can say this is atrial fibrillation. And I remember when I was just in the medical ward and having a routine, very routine round. And we have one patient post-operative. I don't know why post-operative came to the medical ward, but I just come across the patient and I have abnormal irregular pulse. And it was a daycare surgery, very mild, minor surgery. The abnormality, we asked the nurse to do ECG, he did the ECG, and there is absent P wave. And then we called the surgeon who did the operation. I asked him, did this patient having atrial fibrillation? He said, no, he's scared and he came running. He and the anesthesiologist who examined the patient before the surgery, they said there is no abnormality. And then when they examined the patient returned back to sinus rhythm. It was very temporal. But the ECG, it confirming that there is absent P wave. And that was the only same for my diagnosis. Otherwise, they will say that I'm calling wrongly, disturbing all the team. So only absent P wave sometimes might be your document, and it might be the document against you if you miss it. Okay. If there is B wave, but sometimes small, sometimes large, sometimes bifacial, sometimes broad. That means the atrium electricity is not from one generator. Variable B wave, that means there is multiple generators. For every beat, might be there is a node. It is not SA node only. There is many SA nodes producing different types, shapes, amplitudes, and broadness for the B waves. All right, inverted B wave, maybe normal in V1, maybe normal in AVR. Okay, and the BR interval, we already talked about, should be normal. If it is short, can someone tell me, you know, from this ECG, where is the shortness? From where to read? If you forget about the rate and the rhythm and the B wave, presence of B wave is there. If you are not looking for BR interval in name, will you detect this abnormality? يعني إذا ما اشتغلنا ال B wave interval, we know that there is short B wave interval. Will you detect this abnormality?
No.
No.
Of
No.
course, no. Of course, no. And you will miss a valuable diagnosis. Okay. Now, where to read the BR interval? Go to the lead 2.
Lead 2.
In lead 2, see, this is a B wave. This is a B wave. I will magnify it. It is clear to you يا جماعة الناس اللي شغالين بالموبايلات؟
Yes, very sure.
Yeah.
Yes, yes.
Clear.
Okay. See, a very small height from what we discuss. What is your, this patient, what else is there? What else problem?
Inverted P wave.
P wave inversion
Where?
in lead to
Depression. ST.
This is T wave inversion, inverted T wave or ST segment depression?
ST.
ST segment.
ST segment depression.
Mhm.
طبعا, of course, if you have ST segment depression, it may be a mirror image of elevation. So if you have ST segment depression, this is a ST, this is a S, and this is a T. And it is below the isoelectric line. So this is ST segment depression. Where, in which leads? Lead 2, lead 3, and AVF.
AVF.
2 and 3 and AVF. Which part of the
Inferior lead.
inferior? If we have inferior and come here to the lateral, there is also ST segment depression. So it is inferior lateral. Inferior lateral ST segment depression, but there is something else. If there is BR interval, what else abnormal here?
URS complex.
what is abnormality in the QRS complex?
برود في الون الأول.
right.
Broad. قلنا it should be less than 120 small, 3 smalls, and this is broad. Other than broad, it's like a note sheet here, right?
أيوة M shape.
M shape. That means if there is M shape, that means
Right.
Bundle.
Right.
if there is M shape, that means one bundle is affected. That means one ventricle is
Right.
depolarized before the other. Okay, if one is depolarized before the other,
Right bundle brush.
Left.
it could be right bundle brush block, it could be left.
Yes.
We will come how to differentiate between them very easily and very fast.
Into V1.
V1 is negative. Will you change your mind?
Left.
That is it. Okay, what is the idea behind that? What is the idea behind the V? If the V is negative,
Is it new?
the V is negative, that means the axis is deviated more. قلنا ال V ال R wave مفترض يكون شنو؟ هو مفترض يكون negative. But if it is more negative like this one, that means the axis is a little bit deviated to the left. That means the electricity is coming to the right heart first, then going to the left. So the axis, instead of going this way, the axis is going this way. If the axis is going this way, the R wave will be opposite completely, will be very negative.
Yes.
So if the R wave is negative and the axis is twisted to the left and the QRS complex is broad, you are dealing with left bundle branch block. That is the importance of V1 in broad complex with M shape in any leads. And you will find ST segment depression or T wave inversion or deep S wave in the lateral leads, which is M shape here. And it will be like a W. Negative V wave, negative R wave in V1 equal W.
Yes.
The deep S wave in V5-6 equal M
Sure.
shape. Okay? If you forget about the M and W, personally, I just use this one. Broad complex means there is something block. Negative R wave in V1. Okay. Why there is short PR interval? Because short PR interval is one of the differential diagnosis is a left bundle branch block. You remember? Other causes? WBW syndrome.
Yes.
يا بص هنا
بص.
مش هي أصلا ال R wave في V1 negative.
Yes, it is there negative, but in there is broad complex. So broad complex, normal R wave in V1, this is left bundle branch block. Broad complex, abnormal R wave in V1, right bundle branch block.
Right bundle brush.
If it is normal, that is good, but there is broad, which is not good. So bad R wave in other leads, in the presence of a normal lead in V1, that is very bad. This is a normal you don't like. Okay. Any questions so far? Doctor, you agree?
والله الأمانة ما فهمتها.
All right. See. The heart is this way. There is left bundle branch block because of left ventricular ischemia. This bundle is supplied by the blood. If there is ischemia, it will not be supplied anymore. It will die first. So if there is death of the bundle, left bundle branch block means death of the bundle. Death of the bundle, mostly ischemia. Okay. If there is death of the bundle, the electricity will come from the SA node to the AV node, B wave. Coming here, going here this way, right, will be like this. It will start to repolarize, but the left is not depolarized yet. الكهرباء هتمشي هنا. هتديني هنا in the left lead. The electricity this way. So in these leads, in the lateral leads, there will be M shape. If there is M shape in the lateral leads, this is left bundle. In the left bundle branch block, the axis of the electricity, مسار الكهرباء يكون ماشي وين؟ Instead of going هيمشي وين؟ هيمشي this way. فبالتالي lead 1, the electricity is here, it will be strongly negative. It is normal. It is negative. لكن more deep. Why? Because the axis, instead of going here, giving normal negative, it will give super negative, which is normal in V1, but in presence of M shape in the lateral leads, M shape in the lateral leads, in 1 or 2 or 5, 6, 5, 6, instead of M, there will be deep S or ST segment depression equal M shape. That is left bundle block. طيب يجي الopposite direction, a right bundle. It's coming here, normal, here, normal, and then it's going this way to the left. So where is the axis now? Where is the axis?
On the right.
Axis الكهرباء ثانوي الكهرباء تحول اتجاهها. The axis is going this.
Okay.
if the axis is going this way and this our V هنا positive هنا يكون positive لأنه المسار بتاعك بتعكس بدل إن ماشي من الرايت يبقى ماشي من الليفت تو رايت لأنه الرايت blocked V1 will be positive. That is why V1 is positive in right axis deviation. V is positive whether it is a left or right. Clear now? Okay. And WBW syndrome, we said, يا جماعة, there is, I hope there is image here. Yes. This is WBW syndrome. The most common is the accessory muscle from the left atrium to the left ventricle. The bundle of Kint. It is transmitting the electricity from the left atrium to the left ventricle instead of the normal pathway. This transmission of the electricity is fast. It will give us a short VR interval and where is the VR? Where is the B? Diagram here is not very accurate, لكن امسح هنا طوالي البي ويف اصلا هنا بقت ار البي بقت ار ويف البي بقت دلتا very short مع الابستروك راحت. Why? Because there is no time between
Rabbit.
the area
Relaxation.
depolarization because the electricity can delay. An AV node delay the electricity will give time for the atrium to contract and to عشان الفنتريكل تتملي account for this delay. And if they can go at pathway, he will have the voice now clear? Do you hear me now?
أيوة سامعين لكن بيقطع لما تتكلم.
All right. طيب. You are with me now. You know, there in the WBW there is accessory pathway. This accessory pathway shorten the time between the depolarization of the atrium between the B wave and the depolarization of the ventricle, the R wave. It will be very short. This short, instead of B wave, BR interval, QRS, this time will be like this. And sometimes there will be absent B wave. It's not absent. لكنها انجغمت جوا هنا. بقت دلتا ويف. زمن ما في أصلا between the atrial depolarization and the ventricular depolarization. That is why the B wave is inside the QRS. At the beginning of the QRS, it is forming what called delta wave. Okay, if I want the rate is fast. I'm not sure. We can make some delay. We can make delay at least to get an ECG where there is a low rate. In low rate, we can find the short PR. We can give adenosine, blocker, whatever, so it can slow the rate. It can slow the rate even here. Slowing the rate will give me chance to have an ECG where there is short PR interval or clear delta wave. Type. There is only one problem here now. If this patient is having atrial fibrillation, the rate may be 220. The rate of contraction, because it's fibrillation, and maybe more. Most of the time, electricity may be here, right? By the accessory. If a patient with atrial fibrillation and have at the same time accessory bundle of Kint, atrial fibrillation and WBW syndrome, usually these patients are lucky if the AV node is working. But this patient, if we give him adenosine, what will happen? If we block the AV node and remove it from the من المعادلة, adenosine, beta blocker, deltiazine, whatever, any rate limiting drug. If we stop this, all the 220 in the atrial fibrillation will come where?
ventricle.
To the ventricle. That is why in WBW syndrome, we need to roll out atrial fibrillation before giving the patient, adenosine or any AV blocker. And if we block this one, that means the only pathway working is this one, which will transmit all the atrial rate to the ventricle. The ventricular rate will be 220 something, and this is what TAC, and it can transform into VF and cardiac arrest. So a single injection can kill the patient. So WBW syndrome, the treatment is blocker, but we need to be sure that there is no atrial fibrillation. Clear ولا نعيد ثاني؟
كبير.
All right. So the WBW syndrome is an accessory bundle of Kint, and it is usually between the left, in the left free wall. But sometimes could be in the right side, in the posterior, in the anterior. Okay. And the usual pathway connect the left atrium to the left ventricle. This is the most common one. And this is an area of tough question. Where is the bundle? From left to right, or from left to left, or right to right? So it's from left to left. All right. Feature, short BR, delta wave, QRS complex will be broad a little bit. This is a delta wave, short BR and delta wave. Oh, this is if the rate is not very fast. Otherwise, you will not see it. Here again, very short in B2, V2, in lead 2, very short PR interval. Delta wave, you can see it in other leads. Type A and type B for AKT is not important. It's important for MRCP, for MRC, MRChem. Okay, and for cardiologist. So we'll not waste the time on it. A is the left pathway, dominant R wave in V1. Again, it is a matter of axis. In if the electricity is coming here this way, if coming this way, Jama. Actually, it's coming this way and coming to the right. So it will be same like, you know, كأنه في شنو؟ إذا electricity جات instead from the right atrium, from SA node, جات from the bundle of kin to the left ventricle to the right ventricle. تبقى same like what?
accessory pathway.
There is
Same like right bundle branch block. صح ولا لا؟
Yes.
جاية من الليفت، قلنا common is the left wall. طيب electricity جاي from the left towards the right. هيكون عندنا شنو؟ هيكون عندنا axis يتغير.
Yes.
يكون في right axis deviation. What about the R wave in V1?
Abnormal, right?
Positive.
Positive, yes.
Now, I will give you the last positive R wave in V1. Can someone tell me? The right bundle, WBW syndrome, because it will be same like right bundle. Tani, right ventricular hypertrophy. Tani, dextrocardia.
Dextrocardia.
If the heart is in the left. So, positive. V1, the R wave in V1 is also one of the popular leads. Popular wave. Very informative. Okay. Type B, WBW syndrome, is same like the normal pathway. It is coming from the accessory pathway is here. So when we, this is the accessory pathway. So it is same like normal pathway, right? The type B WBW syndrome, the R wave in V1 will be negative because it's normal axis. There is no axis deviation in type B because it is from the right wall of the atrium to the right wall of the ventricle. Clear, Jama? Now you got the difference between the two, and from the ECG you can know You know that this is small BR interval and delta wave. Now, if they ask you high level question, is this is type A or type B? Go to the V1 or to the axis. Now, can tell me what from the axis V if R wave in V1 and 2 اللي 1 and 2 عاملين كيف؟ متقابلين صح؟
Right, yeah.
This is another way.
Reach.
1 and 2 towards each others.
Yes.
متقابلين هذه الأصحاب اليمين. If
Right
both are up, this is normal axis.
normal.
طيب. If this one is up or this one is down, this is left axis.
Left axis.
This is another way.
Leave each other.
Okay. This is type B. Why? Because there is WBW syndrome. In lead 2, there is short PR interval here. Here. And a little bit broad QRS. So it is WBW syndrome. Go to V1. V1 is normal. This is a right bundle. This is a right bundle of Kint. This is a right wall accessory pathway. A right wall is type B WBW syndrome. Clear? Symptoms: palpitation, dizziness, syncope. Diagnosis by resting ECG, electrophysiology study, and ambulatory ECG. The management: if it is asymptomatic, no need treatment. Why? Because it is just an abnormal accessory. If it is asymptomatic, no treatment. What will be our action? Our action is to refer to cardiology to stratify if he is at risk or not. Because if at risk, we need to cut this ablation, radio frequency ablation, cut this one here, خلاص. طيب, why we know, why it is important to know whether it is a right or left? And from ECG only you can know. Why يا جماعة؟ ليش السماني ده معذبنا برايت وليفت WBW?
Site of ablation.
Because if we need catheter ablation, we need to go to the area. Catheter ablation, if it is a type A, we will make a catheter ablation on the left atrioventricular junction. And if it is type B, we will make cauterization here. So that's why it is important for cardiologists to know it is type A or B. Because the treatment is, the localization is important, because the definitive treatment is, what is the definitive treatment?
Ablation.
Definitive management is catheter ablation of the accessory pathway. Why it is important and why it is definitive and why it is 95% cure rate, no need to give medications. And if this patient developed atrial fibrillation, you cannot give the medication. So better if young patients, better catheter ablation. If the patient is symptomatic, same like SVT, because it's actually kind of SVT. Vagal maneuver, adenosine, beta blocker, verapamil. If it is, AV nodal, re-entry tachycardia, narrow complex. Al-AV nodal, narrow complex. If it is with fibrillation, never give this one. If there is fibrillation and the adenosine, verapamil, beta blocker, digoxin, amiodarone, all are contraindicated. What to give? Furosemide or cardioversion, according to stability. Unstable DC cardioversion, and if it's stable, furosemide and flecainide. This is also a very important tough question for MRCP, MRCM, and maybe also to the MRCGP AKT. Again, treatment, asymptomatic, no treatment needed, just refer to cardio. 4, risk stratification. If he's athletes, if he's a captain, air captain, whatever, then you need ablation. High risk occupation, pilot, air captain, ship captains, divers, high level athletes. We can refer those kinds of patients. Otherwise, asymptomatic WBD, no need. If symptomatic, according to and narrow complex, treat same like SVT. With WBW syndrome, treat with either shock or furosemide flecainide. That is a medical treatment. What is about the definitive treatment? Catheter ablation. On the left, if it is type A. In the right, if it is type B. Okay, take 5-minute break, and then we'll come to the bradycardia and heart block. Made it easy, inshallah. يلا شباب.
Okay.
All right. Now to the bradycardia. Bradycardia could be sinus bradycardia. That means the sinus is not discharging fast, or there is AV nodal bradycardia. Again, if everything is normal, the B wave, the BR interval, and the rhythm between the BQRS, but the rate is low. What do you think? Any problem in the rhythm, in the current, in the pathway of the electricity? No. The electricity coming from the sinus node to the AV node to the ventricles, and of course from here to the atrium. But the rate is low. That means the rate is generated slow. This is sinus. Type. If there is delay in time between the atrium and ventricle, that means there is delay here between the atrioventricular node. If there is delay between the atrial contraction and the ventricular contraction, between the atrial depolarization and ventricular depolarization, means there is something between the atrium and the ventricle delaying the electricity. That is AV nodal block. That is a heart block. Okay, because localization is important, ya Jama'ah. If we know that there is localization, there is problem in the AV node. Does it make sense and difference or not? So we can treat the AV node. We can give something to increase the transmission in the electricity in the AV node. Okay. So if it is AV nodal block, that means there is either delay or there is misrhythm between the conduction from the atrial, between the atrial depolarization and the ventricular depolarization. Okay, let's come to the clinical. The first time. If everything is normal, but the time lagging between atrial depolarization, B wave, and ventricular depolarization, R wave. Too much time. Too much time. This is a first degree heart block. And the VR interval is more than 3 small box. Usually more than 5 box. The one of the heart block. 1 large cubic. All right. what are the causes? Any cause that delay the conduction inside the AV node it can lead to first degree heart block. Any defect in the AV node that slows the conduction will lead to no? First degree. What are the causes? The AV node is supplied by negatively by the vagus nerve and positively by the sympathetic nerve. What is the dominant one? Is the vagus. So, if there is high vagal tone, there will be too much delay. That is why in SVT we are treating with increasing the vagal tone. Because the vagal tone will lead to prolonged BR interval, will lead to heart block first degree. Sometimes we are treating SVT with first degree heart block. You got the point, Jama?
Yes, yes.
Dears, please, what we are doing in the course or in open sessions, my target is your understanding. It's not just to show that I am talking, I'm knowing this, I'm knowing this. It's not to show my knowledge. It's to get you have the knowledge. So if you didn't understand, don't let me go. Okay? Bye. All right. Okay, what are the causes of vagal tone? Because the AV node supplied by the vagus nerve. So any medication that increase the vagus, any action, carotid massage, Valsalva, squatting, whatever, increase the vagal tone can lead to first degree heart block and can be used for treating for tachycardia. Medication which act in the AV node slow the conduction in the AV node is a beta blocker, calcium channel blockers, the dihydroviridines, the verapamil and deltiazim, the rate limiting calcium channel blockers, and of course, high dose of digoxin, because digoxin is same like aspirin. It's worked by dose. The doses make difference. So the digoxin toxicity can lead to slow the conduction in the AV node, can lead to heart block and amiodarone. So vagal tone or medication that act in the AV node. Other pathological disorders that destroy or delay conduction in the AV node is ischemia, of course. Okay? If there is the artery, there is myocardial infarction at the area where there is AV node, can lead to heart block. Can lead to any first or second or third, usually causing more than first, causing serious type of AV block, the second and the third degree. Especially which artery, the AV node supplied by which artery in most people?
Right.
By right. That is why inferior MI associated with complete heart block. Why? Because the inferior wall supplied by the right coronary artery And the right coronary artery itself, it is the one which is supply the AV node.
Mm.
That is why inferior MI associated with, in most people or in a significant number of people, associated with complete heart block. Why complete? Because there is complete destruction of, of the
Oh.
AV node. So ischemia, itis, myocarditis, Lyme-itis, sarcoidosis, inflammatory itis, rheumatic fever, abscess, all this can cause, AV block. Not necessarily only first degree, can cause any degree, actually. What else can cause AV block is the electrolyte that work in the action potential of the AV node, which is the potassium. Low potassium can reduce the velocity, can lead to low velocity of conduction in the AV node, can cause, heart block. First, second, third. And of course, there is natural or physiological or idiopathic AV nodal block in athletes. It will be only first degree. Okay, can someone read this ECG? How much is the rate? Between RR, it is regular. Between RR is 1, 2, 3, 4, 5. So 300 divided by 5,
75
60 or 60 something.
something.
Or 60. Okay. So it is not it's not a bradycardia. But at the same time, as I told you, anyone who look fast or in a hurry to this ECG, he will say it is normal. Am I right?
Yes.
It look nice ECG. But come to lead 2, please.
BR.
Check the B, the BR, QRS, T, ST segment, and QT interval. This is the BR more than 1 point
5.
something or near 2 cubic. Larger than 1 cubic. 1 large cubic. Okay. So this is a delay, too much delay between the atrium and ventricle depolarization. And this is a first degree heart block. To confirm this, check BQRS, and the same delay in every beat. It is just a first degree block. The causes, ask the patient. Any vagal tone, any medication, any ischemia, any itis, any electrolytes, any congenital myotonic dystrophy, sarcoidosis. Right. What about
معلش يا بوس، معلش في الاي في ال دي مش شويه برضه بعيده كده فيها
AV?
تشينج،
I'm the same.
بس لكن
Same.
ما نفس الشكل.
Yeah, يعني you are not seeing B wave here. You can say I cannot see a regular B wave. Right? You want to say like that?
ايوه نعم.
Or it is more, actually it is here. There is faint. Sometimes in some leads, the B wave will be, very small naturally in AVL. عشان كده زي said to you قبل قلنا شنو البي ويف افضل حته نشوفها لها وين؟ بيكون في 1 و 2 و AVF. lead 3 is not good, and lead AVL is not good. So عشان كده we are not looking at the B wave in AVL ولا حتى في ال AV ولا حتى في ال V1. اوكي هنا ممكن يكونوا isoelectric B wave لكن that is normal variant. Okay, and you can see here same in this leads there is no يعني it is not very clear. It is not the area where it is not the lead where you can see the B wave. Here ECG looks like normal. Again, the BR interval is a little bit delay, prolonged. See, by experience, you will know that the AVL look like a flat, look like only R waves. But it is here, you can see there is some B wave here.
Notch. Yeah.
A small notch, but you cannot depend on it. But in the
Yes.
are there. And it is regular before every QRS. So it is not type 2 or type 3, and it is not mismatching.
Yeah.
Sinus rhythm. Sinus from SA node and rhythm PQRS. So sinus rhythm. What is abnormality? Is the delay between the atrium and ventricle depolarization. The time where the electricity spent it in the AV node. So this is a first degree heart block. All right. Second degree. Second degree, there is two types. One is Wenckbach, which is Mobitz type 1. There is prolongation, but it is not fixed prolongation. Prolongations that change from every beat. Every beat is having more prolonged than the previous one. Until reach a time where there is significant prolongation that there is no QRS complex. There is drop in the QRS. So progressive gradual prolongation of the BR and the BR immediately after the drop beat is short. Then prolong, maximum prolongation, then absent R wave. This is a Wenckbach. Wenckbach is same like or near type 1 because it is delay in the AV node because of vagal tone or medication. يعني ال AV node فيها محلات short, محلات normal أو normal a little bit long and then very long. That means what? That means it's acting with some rhythm يعني.
Yes.
معناها فيها رقشة يعني. Listen, it is alive and nearly well. So type 1 is benign. Still, there is some organization there. Not like the coming one. Type 2, Mobitz type 2. In Mobitz type 2, there is no progressive prolongation. Not this one. This one is the Wenckbach. Mobitz type 2. Any treatment for Wenckbach, it mostly benign, but it could be due to medication. Could be, of course, due to MI or myocarditis. In a hemodynamically stable patient, Wenckbach have no need treatment. This is example. This is in lead 2 here. There is here normal, here prolonged, here very prolonged. And in the rhythm strip, here normal, little prolonged, abnormally prolonged, very prolonged, and then drop. All these are Wenki Bahayo. And you Mobis type 2. Mobis type 2, there is drop bit without a change in the BR interval. The BR interval constantly normal. Type, what is the problem? Why this is not a good? If the BR interval is constantly normal, there is drop bit.
Drop.
So what is the problem is Mobis type 2? Drop bit. Is the BR interval normal? The BR interval normal. But there is one B wave have no QRS. كله زول بيزوره إلا أنا. Okay? But this B wave, this miskina is serious. It will not, it tell you that there is an unorganized problem. Why there is drop beat without prolongation? If there is drop beat without prolongation, that means the problem is not in the AV node. Is below the AV node. What is the tissue below the AV node?
Purkinje fiber.
This is the AV node. If the problem is here, below the AV node, maybe the fiber, maybe the muscle, and mostly this will be damaged by ischemia. And high likely to be cut completely, lead to complete mismatch. The ventricle beating alone, the atrium beating alone, and the ventricle beating alone. Because this area is weak, can be cut completely. This is Mobitz type 2. Whereas there is B wave, suddenly have no QRS. But the BR interval is constantly constant. Okay? BR interval in the conducted beat remained constant. But after some QRS, maybe 2, or maybe after any 3 QRS, there is one drop beat. So it is called 3 to 1. Maybe after any 2 QRS, there is one drop beat. Maybe 2 to 1. Okay? That is one of the pattern. It is not must. There is 3 to 1. That is why what called regular, irregular sometimes is serious, because sometimes it is Mobitz type 2. These are the examples.
Maybe dissociation.
Constant QRS and constant BR interval. And normal, but sudden drop beat. There is many saying drop beat is not important. Well, drop beat could be the only feature of what? Mobitz type 2, which is the only feature of what? Which disease that cause Mobitz type 2? MI, especially anterior MI. So can ask you one squeezing question. They bring for you ECG with Mobitz type 2. Is this inferior MI or anterior MI or lateral MI or posterior MI or no MI? Inferior MI, complete heart block. Anterior MI, Mobitz type 2. Why anterior MI causing? Why anterior MI causing Mobitz type 2? Anatomy linked to electricity. And defect in the anterior, left anterior descending, the LAD, which supplies the area below the node. The AV node supplied by the right coronary artery. The area inferior to the AV node is the septal area supplied by left anterior descending. Which is serious. Yes. So we need to link Mobitz type 2 to anterior MI. It is not just diagnosing the MI, it even localizes it. It could be Lyme, myocarditis, any itis in the septum, any infiltration disease which is usually affecting the septum, myeloidosis, sarcoidosis, hemochromatosis, cardiac surgery affecting the septum and the septal area and the anterior wall. Okay, and of course, the medications that affect the AV node can affect the infranodal area, like digoxin, beta blockers, and dihydropyridine calcium channel blockers, amiodarone, and amiodarone. What is the clinical significance? Equivalent, it's serious, so it is a medical emergency. Why it is a medical emergency? Can someone tell me? Why Mobitz type 2 is serious?
لأنه ممكن يتحول لكومبليت هارت بلوك.
Yes, it can transmit, it can go to complete heart block. Okay. And complete heart block, what is the seriousness of complete heart block? And I will tell you one story. One time, we have a patient in the ER, and he is he is chatting in the mobile, laughing, and his ECG, there is complete heart block. What vital is normal? The patient generally is more, is better than all the staff who are in the shift, because at the end of the shift. And there is complete heart block in the ECG, definitely no joke. And the doctor who is showing the patient was relaxed. He want to request troponin, CKMB, electrolytes. And then suddenly we realized that this is a heart block, complete. And it should be a medical emergency. We should call the cardiologist immediately and put a pacemaker. Percutaneous, then prepare for definitive permanent pacemaker. Why? Why complete heart block is serious? And even the second degree Mobitz type 2 is serious because it will transform into complete. Why complete is serious? Even if the patient is stable.
Can lead to sudden death.
Sudden.
Can lead to asystole. It can transform into asystole because there is block. There is no conduction from the electricity of the atrium to the ventricle. One of the muscle, one of the fiber of the ventricle took the rule. Start to generate a ventricular rhythm. قلنا the atrium is depolarized and contracting by a rhythm from the SA node. But the ventricle is generating its own electricity from one fiber to one fiber, which will not stay for a long time, which can stop at any time, because it is not created to work as electrical generator. It will just take the rule for few times if the doctor catch it and treat it. Otherwise, it will stop working. It will lead to asystole. Okay? That is why third degree heart block is a top emergency. And even Mobitz type 2, top emergency because it can go to third degree. Admit, monitor urgently, temporal pacing if unstable. If it's stable, prepare for pacemaker permanent one. And if you call cardiologist, any cardiologist, you call him, I have a Mobitz type 2 or third degree heart block, he will come running. Example. If the ECG is looking, you finish the rate, bradycardia. How much is the rate? 1, 2, 3, 4, 5, 6, 7. So 300 divided by 7, it is like 40 something. Very slow rate. But there is narrow QRS complex. Alhamdulillah. There is some fibers is working. Leads is okay. But there is drop beat. There is drop beat. Yes, there is drop beat. Is it Wenkibach? No. Al-Haq. This is not a Wenkibach. That means this is type 2. If there is drop beat without progressive lengthening, that is Mobitz type 2. Okay? A drop beat in ECG, ya Jamaa, is serious. Okay? Third degree heart block is easy. وقلنا يا جماعة drop beat. This ECG is patient is having anterior MI. Third degree have inferior MI. Third degree complete ablation of the AV node. AV node is not there. No conduction between the ventricle and the atrium. So atrial contract, maybe at the same time the ventricle contract. They can relax at the same time. They can contract at the same time. They can ventricle contract before the atrium. الأمور جاتت. Okay? So there is tourism. There is tourism. Yes. No relation between B and R wave. But B wave regular. R wave regular and same constant. You got this point? ولا عيدة تاني؟
معلش عيدة تاني يا أبو.
Yes, there is no mismatch. يعني BR خلاص lost. There is B absent, BR, B absent, B long time, then R. But there is no mismatch. There is no matching. الاتريوم عملوا انفصال. لكن the atrial rate because it is the atrial rate is generated from the SA node. The time is fixed between the atrial beat and the atrial beat. So if we make an atrial ECG إذا كان مسحنا R wave هيكون عندي شنو؟ regular BB wave. Same time. Equal. Regular BB waves. Interval. طيب إذا مسحنا البي wave, if we delete the B wave and we just look at the R wave, RR is regular. طيب يا أخي RR are regular, BB are regular. Why you are not working together? Because there is complete block. Electricity to the atrium is good. Electricity to the ventricle is generated from one fiber, but producing electricity at the same time at equal rate, at equal rhythm, like in own rhythm. So the atrium have its own rhythm, which is rhythm, and the ventricle have its own rhythm, which is rhythmic. You got the point, Anjama? Complete heart block.
Yes.
All right. Causes inferior MI. أو إذا كان there is artery, the artery supplying the MI, the AV node is خلاص destroyed. Maybe anterior in some patients. لأنه in 65% of patients, the AV node is supplied from the right coronary artery. That's why in 65 associated with inferior. In other, it is supplied from the anterior, from the LAD, which is associated with the anterior MI. So complete heart block could be from inferior, could be from anterior. Okay, like in Mobis type 2, always anterior. Right. Features will be severe bradycardia, dizziness, syncope because of stroke atom attack, heart failure, sudden death. It's a medical emergency. High risk of ventricle stand still or asystole and sudden death. Management ABC. Atropine may help, especially in inferior MI. But if it is completely destroyed, خلاص. Atropine will work opposite than the beta blockers and the calcium channel blocker. It can increase the AV nodal conduction if the AV node is still alive.
Alive.
Okay. And sometimes the AV node receive collateral, yani supplied from the inferior and from the anterior, from left anterior, from the LAD. So we can try atropine, no problem. But if there is no, if it's not working, then as per the SLS, temporal pacing, waiting for permanent pacing. And that patient, he developed severe bradycardia, 35, 30 something. And when because of his stress, when he know that he's having heart block, he become more. And we put transcutaneous pacing, although it is very painful. Like we have no choice. And then the cardiologist came and take him to the theater, to the permanent intravenous pacemaker. That is a pathway for the approach to the management. A trial of atropine, temporal pacemaker, planning for definitive treatment. Maybe a few hours later, they will do, permanent pacemaker. Yani see, even the few hours waiting for the preparation they can put a pacemaker percutaneous, which is painful. Sometimes you need to sedate the patient. All right, summary. Mobis type 1, Mobis type 2, Mobis and complete heart block. Now, what is DCC?
The complete heart block.
So there is
Inferior MI.
two, there is, this is a lead 2. This is lead 2. There is
B.
B wave, prolonged
B. Prolonged B.
PR interval. Next to it, B wave, and there is no beat or very abnormally prolonged. The third one is B wave but short. So prolonged, short. That means there is no mismatch.
Complete
No
heart.
match.
Third degree.
No matching. Third degree. What else? Big abnormality here. Now
Inferior myocardial infarction.
there is ST elevation.
Yes.
There is ST elevation into
2-3 AVF.
IVF and AVL.
AVL, yeah.
AVL is left. AV left. So inferior lateral.
Lateral.
Okay. Inferior lateral MI. This is extensive MI. Maybe double vessels, maybe triple vessels disease, leading to inferior and to lateral at the same time. Inferior lateral, inferior by right, lateral by left. What do you think? Double vessels or not?
Yes.
Double vessels. Okay. And in this patient, there is a complete heart block. We don't know it is because of the right artery or because of the left. Now, this one. See, what is the biggest abnormality here? Abnormality. أول ما تشوف
برادة أول حاجة.
severe bradycardia.
Yes.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. This is less than 20 something or 30. Type severe bradycardia. Is there any matching? Go to lead 2. The lower down. Okay. Drop.
Prolonged BR.
Very prolonged. Very prolonged. Too much prolonged. And drop. Is it a Wenckebach? No. Wenckebach will never cause, too much delay like this. Too severe bradycardia like this. Okay? So the one which is look like a Wenckebach in a severe bradycardia, this is actually complete heart block. عشان ما تقول والله this is هنا more prolongation and drop it. Very severe bradycardia. This is not a Wenckebach. Here, last strip. B wave. Prolong. Short. Normal. Prolong. If we want a BB interval is fixed and normal. B.
Third degree. B.
Like normal. R like normal. But the duration between the V and R is different from beat to beat. So this is a
third degree.
Complete heart block. How to manage? Permanent pacemaker.
Pacemaker, yeah.
All right. QRS, should be narrow, should be upright in 1 and 2, and the left lead. Okay. If it is wide, maybe the conduction is from the nerve muscle to muscle, or the generator in the muscle, or the electricity come from the right side, or from the other vessel. So the causes of wide QRS, bundle branch block, or ventricular rhythm. In the bundle branch, the rhythm is from the other bundle, left from the right bundle, right from the left bundle. So bundle branch or ventricular rhythm. That is wide QRS. All right, Q wave. There is normal Q wave. When we are talking about Q wave, we are talking about the pathological one. Is there any Q wave in this ECG? Which lead?
Lead 2.
Lead 2, very good. Lead 2 is deeper. Okay. What is the significance of a Q wave? All impaction.
Impaction. Yes.
Which wall? Which area? Inferior.
Inferior.
That is why it will usually be in lead 2, 3, and AVF.
VF, yeah.
Okay. Actually here, AVF is deep Q and small s.
Mm.
In 3, same. Okay. The causes of Q wave, usually, the most common one is old inferior wall. It could be due to evolving MI, hypertrophic cardiomyopathy, dagger life, زي الخنجر, كيو ويف الطويلة زي الخنجر.
Dagger sign.
And the other myocarditis or whatever. So pathological Q wave is a previous transmural. Why is there is Q wave? The Q wave will tell us there is complete ischemia and necrosis of the muscle from endocardium to the pericardium. It will give us the Q. Dead myocardium through and through.
Stone.
Okay, left bundle we know. We discussed it, Jama. Anybody? This is a V. And this is a 6. In either V6 or lead 1. Will be like M is safe. All right, any question? This is example. See M in V1 in lead 1. and deep
What?
S in lead V6. So M in lead M in V in lead 1 and deep S in V6 in the presence of normal R wave, which is negative.
Left. LBB. LBB. LBB.
Causes of left bundle: destruction of the left ventricle or the area of the left ventricle. Where is the left bundle? Left anterior descending artery or
Left.
the MI. That's why if it is new, that means there is new damage. Okay, it could be due to inferior, but it is usually old. Previous MI or acute MI. Depends on the symptoms and the old ACG, if the patient is having old ACG. Type. Why we are saying that, the left bundle branch equal MI? It will mask our as a signs of acute MI. And it is usually coming with due to damage, necrotic damage of the area where there is bundle, left bundle, which is the most important bundle. Okay, so the onset of left bundle branch block with chest pain in a patient with no history of bundle branch block in ECG, we need to deal with it as equivalent to estimation MI. Poor prognosis. Type. This is a high level differentiation between ischemic and non-ischemic left bundle branch block. We are using Garbosa criteria usually, lakin it is not important for you. Any to differentiate it from the history, you can differentiate. Okay. Otherwise, use this Garbosa criteria. If it is there, this is pointing towards acute ischemic. This is Garbosa criteria. We'll go into detail of it. The right bundle branch block, the bundle is going to the right, is damaging the right, the axis is deviated to the right, and the M shape will be in the opposite direction. Instead of being in lead 1, it will be in V6.
V6.
Okay? And at the same time, there will be positive R wave in V1. Any question, If it is only, if it's asymptomatic, no need treatment. If there is syncope, yes, we will refer, even if it is a right bundle branch. If these are the territory, V1, 2, 3, 4, all anterior septum. V2 and 3 is septum, which is rare, alone. And the remaining, Jama. Okay, we will stop here. Ischemia already we discussed it. ST elevation and ST depression. We discuss it in ischemic in chest pain.
Yes.
Any question? That is the elevation look like, you know.
That's why. fish شايل حق المغاربة. That's why.
There is no no exam without 2-3 ECG in OSCE or AKT. Okay, for joining the group, I will send the link. Any question, anyone? Atrial fibrillation is important, like a big topic. We will discuss it in the next session, inshallah, in the structural heart disease, atrial fibrillation and heart failure, myocarditis, pericarditis, and valvular disease. In summary, what is the biggest problem in atrial fibrillation? There is two issues. Number one, ventricular rate. So high ventricular rate. The other problem is that
Regular risk.
the atrium not contracting, just
flickering.
And in the left atrium, there is one pocket called appendages. In this pocket, if the atrium is not contracting, there will be clot formation here.
Thrombus formation.
So we have two problems, the fast rate and the clot. This clot, at any time, it can dislodge and go inside the left ventricle, and from the left ventricle, it can go up to where?
Brain.
Go stroke. Going down, cause mesenteric ischemia. Why there is clot? Because in the appendages, the blood is not moving. So atrial fibrillation, we have two problems, either rate or clot. Type. There is fibrillation. If young patient, new, and we can get a sinus rhythm, okay, well and good, but that is not usually the case. So we can treat the, the rate. Type. What to do for the clot?
dual anticoagulant.
Coagulant if there is risk of shooting of the clot, measured by CHA2DS2-VASc score. If the CHA2DS2-VASc score is high, then prevent the clot formation, the clot dislodgement. Okay, that's it. That is the most important part of the atrial fibrillation. The detail, we will discuss it later, inshallah. When to treat with the rhythm and what are the medication used for the rhythm or electricity if unstable, and how to treat the clot by DUAC. Okay, or warfarin. That's it, to prevent primary prevention of stroke. If a stroke already happens, secondary prevention of the stroke.
Yes.
That is in a summary, in a very, very, very concise summary. We will discuss the detail, inshallah, later. Okay. Any question?
بص
Yes.
معلش في الموبت 2 قبل في صورة كده بتاعت ECG قبل الكومبليت هارت بلوك تحت.
It show.
تحت شوية ده. أيوة دي الفوق دي لا
ECG قصدك؟
أيوة دي ECG دي فوق شوية معلش. أنا داير موبت 2.
ما بتستوح يكون تحت هنا.
أيوة تحت معلش. تحت شوية.
This is Mobitz 2.
لا في صورة كده بتاعت ECG كده. لا تحت شوية. آخر صورة. أيوة دي بس دي أيوة. لا فوق شوية فوق ما تحت الفوق. أيوة دي بس معلش. بس أنا بس أنا ما عرفت QR ضرب وين بالضبط.
Yes. طيب, go to the rhythm strip. This is the rhythm strip.
طيب.
Okay. This is QRST. This is B. There is drop here. This is B,
Yes.
QRS,
Yes.
A, QRS, B, QRS, QRS. Constant. There is drop.
هنا في drop here.
And there,
أوكي تمام.
هنا
كده عرفتها.
so it is like a
برضه.
4-1.
أيوة. تمام يا باشا شكرا.
شوف أول ما
دي
تلاقي
كلام.
drop beat وما في progressive lengthening. دي اسمه شنو؟ كل زول بزوله إلا أنا.
موبت 2.
موضوع خطير.
أيوة ده يمكن يمشي لكومبليت هارت بلوك أسيس دول. لازم نلحق.
Yes.